Ladies and gentlemen, dear colleagues, it is my great pleasure to be again at the Heart Failure in Focus. And I would like to thank you very much, the organizing committee, for having me. I'm going to address one of the most important topics in the world of cardiomyopathies, and this is hypertrophic cardiomyopathy. I'm happy that I was one of the founders of the European Society of Cardiology Working Group for myocardial and pericardial disease. If we talk about hypertrophic cardiomyopathy, we may say that the disease is defined by the left ventricular wall thickness, more than 15 millimeters, in any of the myocardial segment, but not explained by any of the loading conditions. The septum is one who is hypertrophic at a higher extent. One of the most important topic in hypertrophic cardiomyopathy, which needs always to be addressed, is a sudden cardiac death risk assessment, which has four important risk factors: clinical, genetic, EKG, and imaging. Going further, we may say that hypertrophic cardiomyopathy is one of the diseases which is mostly genetically based, and most mutations affecting this disease are based on sarcomere proteins as myosin binding protein C and beta myosin heavy chain. Mutations on Z-disc proteins are not really very frequent. It is important to us for understand that cardiomyosin binding protein C mutations may be associated with the missense gain of function mutation and myosin hypercontractility, and both of these genetic malformation are the good target for cardiac myosin inhibitors and potential gene treatment. If we look at the genetic basis of the disease, we may say that carriers of gene mutation have a much higher adjusted risk of adverse outcome, particularly for ventricular arrhythmias. These carriers has 7-time-fold higher risk, and as you can see from the graph, the differences are striking and need to be clinically acknowledged. Left ventricular outflow tract obstruction is extremely important because it's associated with worse outcome. If we look at the different groups of hypertrophic cardiomyopathy, non-obstructive, provocable obstruction, and rest obstruction, we can clearly see the increase of mortality and significant cardiovascular effect in patient with fixed obstruction. 2023 SC guidelines for management of cardiomyopathies gave us an excellent overview and algorithm how to treat those patients. If we have maximum provoke peak gradient of more than 50 millimeters of mercury, we need to go for the left ventricular outflow tract management. But in another group, according to the results of exercise stress echocardiogram, maximum provoke left ventricular outflow tract obstruction, we may use a different, not only diagnostic, but the treatment options. What are those treatment options? In the patient with symptomatic patient and left ventricular ejection fraction more than 50%, the medical treatment with beta blockers, diltiazem, and low-dose diuretics is warranted. In patient without left ventricular obstruction, optimal medical treatment can be used. And in patient with atrial fibrillation, what is mostly recommended is the rhythm control. If we look at the novel possibilities for non-obstructive hypertrophic cardiomyopathy, SGLT2 inhibitors are one of the important points. They are improving diastolic function as well as functional capacity, not influencing the left ventricular mass changes. After 6 months of therapy, SGLT2 inhibitors, and that will be the open label study called Sonata HCM, which is practically multi-center study to evaluate the efficacy of and safety of sotagliflozin in symptomatic obstructive and non-obstructive cardiomyopathy, with the goal of determining the changes in symptoms and functional limitations in patients with symptomatic hypertrophic cardiomyopathy treated with sotagliflozin. If we go to the pharmacologic management of hypertrophic cardiomyopathy, it is clear-cut that first-line therapy includes non-dilating beta blockers, verapamil and diltiazem, and recently cardiac myosin inhibitor, mavacamten. The left ventricular outflow tract obstruction is treated with septal reduction therapy, and septal myectomy is preferred to alcohol septal ablation. Septal reduction therapies should be performed in patients who are symptomatic despite optimal medical therapy and with outflow gradient more than 50 millimeters of mercury. One of the breakthrough in this field is myosin inhibitors, Explorer HCM study with mavacamten, in whom mavacamten exerted a clear-cut reduction in left ventricular outflow gradient and left ventricular ejection fraction over time. The safety of the drug was excellent, and mavacamten was well tolerated with very few serious adverse events. However, the careful up-titration in this patient may be also warranted. Valor HCM, this is the comparison of mavacamten in patients eligible for septal reduction, clearly showing that mavacamten is significantly improving the symptoms and also having the less requirements for septal ablation. Sequoia HCM, another drug, aficamten, second in class, shorter half-life, more consistent pharmacokinetics and pharmacodynamic effect. And this one is probably very important in having all these drugs on the board and with a good clinical effect. Aficamten is one of the drugs which can be preferably used in this patient, and in Sequoia HCM, the pre-specified endpoints, primary and secondary, were achieved. MAPLE HCM aficamten versus metoprolol monotherapy clearly showed that aficamten was superior to metoprolol in improving functional capacity and hemodynamic profile of this patient. If we would like to mention the innovative gene treatment for obstructive hypertrophic cardiomyopathy, we may say that the majority of mutation which result of unstable and absent cardiomyosin binding protein C may be due to only one functional gene copy, ultimately causing hypertrophy. And possible treatment options include gene replacement targeting all mutations at once by gene transfer. First in human trial gene replacement, so-called adeno-associated virus-based delivery, is very innovative and used in investigational gene therapy, TN21, for the treatment of hypertrophic cardiomyopathy, which is AAV9 capsid delivered to the working patient with hypertrophic cardiomyopathy, and once in the cell, the working gene may help make the protein needed to restore normal, typical heart function. The drug is given one time with intravenous infusion. What I would like to mention are two very innovative approaches. One is RNA therapies and allele silencing, based on the mouse model basic research, which will be able to silencing the mutant cardiac myosin binding protein C. Another is CRISP gene editing and base editing, which are now ongoing. The two preclinical studies use CRPS gene editing. Ladies and gentlemen, let me say that it was my pleasure to be here. I tried to underline the important directions in the new treatment of hypertrophic cardiomyopathy, but the future will show which one is going to stay with us in the clinical ground. Thank you very much for your attention.